As the slide says, IRC's largest sector is health, and in 2020 we provided access to healthcare services for more than 27 million people across 32 countries. Based on WHO UNICEF reports, we all know IPC in health facilities is chronically poor globally. Poor knowledge and low adherence to IPC practices stems primarily from a lack of investment in water, sanitation and waste management infrastructures, which is preventing staff from practicing strong IPC procedures that are required in such facilities. It's also well documented that during infectious disease outbreaks, healthcare facilities can play a major role in the transmission of these diseases, putting not only health staff, but patients and surrounding communities at unacceptable risk. IRC had no standardised assessment or monitoring tools to detect gaps in IPC status within the health facilities we support. To this end, and in light of the emerging COVID pandemic, we developed a minimum package of IPC standards for COVID, which aimed at identifying gaps, as well as enabling rapid IPC improvements in the health facilities we support. We reviewed and adapted WHO UNICEF's WashFit tool to take into consideration COVID, and looked in more detail at IPC requirements rather than just focusing on basic wash infrastructure. One of the main changes we made was in the inclusion of a screening triage category, as well as including availability of essential COVID PPE materials, which sit under the cleaning and hygiene category. More minor changes were in the scoring system and the assigning and producing aggregated scores for individual categories so that comparisons could be made and also help with tracking of individual health facility performance over time. Another minor change the IRC made was in the scoring system. Each standard or question under a category was given a 0 score when it did not meet that standard, a score of 1 if partially met, and a score of 2 when it fully met the standard or question in a category. IRC provided guidance to assessors on how to decide the correct score for many of the questions. The overall IPC score is calculated as a percentage across 5 categories. IRC set a threshold for meeting the minimum IPC in a health facility when the overall score was 80% and above. All assessments were uploaded from ComCare into a Power BI dashboard using a colour or traffic light system. This assisted with rapidly visualizing the individual country results. Using the dashboard also allowed countries to drill down under each category or to compare trends from follow-up assessments to pinpoint specific standards. Under the colour or traffic light system, scores of 64% and below are coloured red to indicate a fail. A score between 65% and 79% indicate that a category partially met the standards and is coloured yellow. A score of 80% and above, which fully meets IRC's prescribed standards, are coloured green. IRC's baseline assessment was completed in 1,106 health facilities across 22 countries and took place between the 26th of August and the 17th of December 2020. As you see from the chart, only 14% or 152 of the 1,106 health facilities met the overall IPC WASH standards. When these results are looked at in more detail, the category that contributed to the low overall IPC scores were lack of screening or triage, poor IPC management within the health facility, and lack of sanitation. The low sanitation category score was mainly due to the lack of proper clinical waste management, covering low or no segregation of waste within treatment rooms, to poor or no final safe disposal provision. Although the highest scoring categories were water supply, followed by cleaning, hygiene and PPEs, caution must be taken when interpreting these results. When the individual category results are drilled down further, the scoring mechanism used by IRC masks some of the true outcomes. For example, some health facilities could have an overall WASH IPC score of 80% and over, yet fail many of the standards under the water supply category, primarily because water within these health facilities may not be treated or chlorinated. Many of the health facilities did not routinely test their water, nor did they have a minimum 2 days storage capacity for sporadic supplies, and so on. This discrepancy in the scoring system has revealed that we need to review priority standards to help improve meaningful WASH IPC compliance. As seen from the chart, the results from IRC's baseline highlights many weaknesses in IPC across all categories in the majority of health facilities participating in the baseline. These poor results emphasise the very real and critical need for IRC to prioritise WASH IPC within health programmes. To expand on the overall water supply category results, this chart has drilled down on the water category of the 152 health facilities that met the overall IPC score of 80% and above. On the surface, as these health facilities met the overall IPC score, and we have assumed everything is good IPC-wise in these facilities, you can see the results that are drilled down show that a health facility can easily fail to meet the required water standards. This is not good. In addition to this, and even if the health facility meets all the water standards, it's essential to clarify if the water is actually chlorinated or treated. So are they routinely testing for free residual chlorine levels, or are they conducting bacteriological analysis? Many of IRC's health facilities have wrongly assumed that pipe water provided by a municipality has been chlorinated or has undergone some form of treatment. So far, the reality around this is the exact opposite. It is therefore crucial that health facilities confirm the quality of water, basically because the water, if it is non-potable, may affect other minimum standards such as hand washing, availability of drinking water, and even cleaning and disinfectant practices, which all depend on this water and could be potentially using fecally contaminated water, therefore can never truly meet the IPC standards. This table shows a sample of some of the 22 countries that have conducted follow-up visits with varying results. Take Sierra Leone, for example. They had managed to improve overall IPC scores by the 5th and 6th rounds of assessment, where they moved from failed to meet to partially meet overall standards. Sadly, by the 7th and 8th round of assessments, the scores started to drop. The same for Mali and to a certain extent Nigeria. However, Uganda and Kenya have improved and, more importantly, maintained their overall high IPC scores, apart from a small dip on the 12th round of assessments in Kenya. The great news is that the health facilities in these countries have maintained their high score through IPC improvements. One takeaway from these countries is that improvements have been made. The baseline assessment results only had one country meeting the IRC prescribed overall IPC score, which was Kenya. By the third round of assessments, this had jumped to having 4 countries meeting the overall IPC score. Another takeaway from the selected countries is that improving the initial baseline scores can take time. Also, due to many of the individual standards or questions being dependent on consumables such as non-reusable PPEs, cleaning materials, etc., the need to constantly follow up is crucial to maintaining overall IPC scores once they have been reached. Countries and health facilities should not become complacent once they have attained the desired IPC score. So the next few slides are highlighting some of the constraints and limitations as well as lessons IRC learnt from the start of conducting the baseline survey. One of the biggest constraints that we had was that there was limited budgeting done, especially for some of the more expensive infrastructure improvements like clinical waste management. We also didn't have dedicated wash staff attached directly to any of the health facilities, and again, this was through lack of funding or lack of assigning budget specifically for that. When we were doing training on the assessment tool, the assessors were trained by non-WASH people. So this created a lot of confusion and a lot of problems in how various different questions were answered. And then finally, some of the health facilities that were in the baseline survey are no longer being supported by IRC, so have skewed our ongoing results. Some of the limitations that we found that created problems were that we did not weight priority standards, and this masked some of the true results. The adapted tool that we developed did not help identify which sector within IRC should be accountable for the non-compliance of the standards, and this has led to a lot of lack of clarity on responsibility for ensuring improvements. And finally, at least 5 country programmes in the baseline survey do not have community wash interventions, therefore no wash staff to assist the health teams with IPC infrastructure improvements. Finally, the lessons that we learnt and the lessons that we should be taking forward is we need to review the scoring system, especially for key priority standards. Refresher training on the assessment tool must be done by WASH technical people. And most of all, routine and regular assessments must be conducted to ensure the standards do not drop. Funding for IPC and WASH in health facilities has to be prioritised and must always include in donor proposals. Funding for clinical waste management as well as water testing and treatment must be seen as a top priority, and some of the key IPC WASH interventions can actually be done with minimum funding, but there has to be dedicated IPC teams. So ways forward. So within IRC, we will be making sure that IPC is seen as everyone's responsibility and not just shouldered by a WASH team. Internally, we have made it mandatory now for all new proposals under the health programming to budget for IPC staff and also IPC improvement activities. And we will be lobbying donors to prioritise and support all IRC proposals covering health